Welcome to the Compromise to Alchemize podcast, and I'm your host, Dr. Neel Bolchandani. Well, good morning and good afternoon to you, Kevin, as you're streaming in from the Chicago area, which is where I was born and raised, an hour south of there. So I'm going to just kind of tell everybody who you are, but those out there who know Kevin, you know Dr. Boyd, Dr. Kev, as you say. It's quite an honor to have you in front of my audience and just chatting with you. We've had some really good conversations, but I'm excited to share your wisdom with the broad range of people that come to my podcast, because some of them know a lot about health, but very little about the expertise that you carry, which is quite unique. And of course, this is the Compromised to Alchemized podcast, which I'll get into later, but mainly, how can we go from compromised airways to alchemized airways? How can we guide people in healing when the problems can seem so daunting? And you're one of the people out there that's figured out a lot, and not only helps families, helps children, especially at that under 72 months age range, but you help educate the field, and you're quite a known teacher in the field. So I know you're a pediatric dentist, and of course I've interviewed Milt on the podcast. That's yet to air, but by the time people see this on the podcast, they'll have seen your good buddy and some of the story of how you two have collaborated, and how I call it, you've influenced him in such a beautiful and profound way. So some people will have a little bit of that history, but some people will be tuning in wondering, like what you have to share for us today. So yeah, without further ado, I'd like to say, Kevin, welcome, and I'd love to have you just share with us a little bit more about some of your background.
Well, you brought up Brittany and Milt, and those are two of my inner circle. The circle's getting bigger, and I couldn't be happier. I've never enjoyed being a dentist as much as I do now, because I don't really do conventional dentistry anymore. I haven't picked up a drill in maybe 10 or 15 years. It's been a while, and tooth decay is something that drives dentistry. And what I am trying to introduce is this whole concept that tooth decay is 100% preventable disease. It didn't afflict mankind until shortly after what we call the agricultural revolution, when we discovered how to plant grains and grind them up and separate the fiber. And so we just, that's something that is real key to my hypothesis, my mission, if you will, is to promote healthy eating. And that isn't just nutrients, but that is texture, chewing. We've lost our ability and desire to chew because things are so overly processed. And so that's really a foundation to all this. And when I sort of started onto this journey, maybe 15 years ago, when I was approached by the head of sleep medicine at was then called Chicago Children's Memorial Hospital, Dr. Stephen Sheldon, a pediatric neurologist and a pediatrician, who was frustrated because pediatricians were not really latching on to what he was trying to say. Look, this needs to be included in your assessment of children's health risk. Are they sleeping well? Are they breathing well? And he had heard about some work that I had been doing with a local dentist named John Kelly, who used to be the team dentist for the New Orleans Saints. And it was all about healthy jaw joints and breathing. And he wanted me and John to start teaching the sleep doctor fellows, and to maybe get the pediatricians and the ENTs to start paying attention to the things we were doing. It's a shared domain. You say, well, the airway, that's the domain of the respiratory therapists and the pulmonologists and the ENTs. Well, it is, of course it is, but it is a shared domain, because the airway is first influenced starting with the nose and the mouth. And you know what? Everything's above the clavicles. That's the collarbone. That's the shared domain with dentistry, oral health. And it just ballooned from there. When Dr. Sheldon had us rounding with him in the sleep medicine clinic that is now called Lurie Children's Hospital, that's when things really started to change. And from there, you're familiar with my work, and other people are. And I don't know, I'd like for you to just sort of maybe tell me what you think of it as a healthcare professional, Neel, and what you think your audience, what questions maybe they have. Maybe they've already asked you some questions based upon what Brittany was talking about. I don't know. I'll let you steer it from here. How's that?
Yeah, I love that. And I also want to mention some others that we know dearly in common, like Joy Moeller, down in Pacific Palisades, and she's doing okay. She said she's still seeing her clients via Zoom, her patients, and that's what's keeping her up. Is like her, despite losing her home,
Yeah,
she's with
I heard.
she's with her family, Samantha and Mark, but and they're safe over there east of that region in LA.
Good.
And she
Good.
has family down, so she's good. But we could dwell on that because it's a hard topic with her losing her home and others that we probably know in common that have also lost that along with all the others.
Mhm.
But what keeps her afloat, she said, is her patients. Like, she loves to care for them, and she has. She's what, 72 still? She might be 73. So she's dedicated, and
She's a
she
child. Says she's 72. That's a
yeah,
baby.
that's a
You
baby.
know, she's
And
she's entering middle age.
when I was with her down in because I've interviewed her on the podcast, and when I was with her in her office in Pacific Palisades, boy, was that this summer in July, and I did a bodywork session for her. We talked about her book and then my floor of the mouth protocol, but we talked about you. She's like, "Do you know Kevin?" I'm like, "Well, I know of Kevin, and I would love to reach out to him." And she's like, "You need to talk to Kevin. You need to, because she knows how wise you are, and she also could see how linked up we could be in terms of the way we look at things." And I wanted to mention that as like both a reference point for people, but also a bridge of what we do. Even though some people would wonder, like, what does what I do have to do with what you do? But there are others too. There's so many others that you and I were talking about this at the WDSS, the World Dental Facial Sleep Society Congress in San Francisco, when I was sitting there with you and Milt after the Stanford experience and all of that with these amazing people. And it's like, there we are, a bunch of people who are very different in what we handle, what we cover in our own respective journeys. But where we link and, coordinate, I think is that, a lot of people who follow me want to know what work I do with infants or with children whenever they're going through, you know, airway issues, and whenever they need it, adjunctive procedures like expansion, and how I work on the floor of the mouth and the entire body, all the organs, all the muscles, all the bones, and how do I guide people in movement, but also freeing up areas so that they can do well. But I mean, it takes a village. And as kind of what I do with the village, I see, I especially love caring for, well, I just say kids of all ages. But yeah, I think I want to go to that point where you have somewhere in the 72-month age. I think there's so many directions we could go, but I would love to know, just for those people out there, why do you focus, why do you have that number in there, 72 months, even though I know the answer? Like, what's your big target? What's that target, and why is that so important?
72 months is the same as age 6,
Yep.
okay? And the American Academy of Pediatric Dentistry, in conjunction with the Academy of Pediatric Medicine, Pediatric AAP, I think it was back in the 90s, a lot of kids had tooth decay so bad, they defined it as any child who has any cavity before the age of 72 months old that's diagnosed as early childhood malocclusion. And if there's more than one, or the kid's under 3 years old, it's called severe, and that got into the International Classification of Disease. That changed things with insurance. A lot of kids have to go to the operating room, and there's pre-op costs, post-op costs, operative anesthesia costs. Sometimes we have to admit these kids afterwards. So that was the early childhood. There's different definitions for it, but in terms of what the ICD, International Classification of Disease, is it's something that will get medical insurance, not being able to punt and say, oh, that's a dental problem, they need to consult their dental. No, it's a medical problem. So I'm thinking the same thing should happen with another component of what's considered oral health, and that is the alignment of the jaws, faces, and teeth. And they call it malocclusion collectively, and that's where orthodontists, that's the actual need for orthodontic treatment didn't really become evident in humans till about around the time of the late 18th century, the Industrial Revolution coming in, the Scientific Revolution, mechanized food supply, women entering into the textile mills and no longer being able to stay home and baby-led wean for 3 years. And the food got processed, and we got this thing called baby food, which is it's got its good and bad. There's no texture to it. It was originally made and advertised, and I grew up 40 miles from Gerber. Used to be a canning factory in the 1800s, and it was advertised as being for invalids, which is a politically incorrect term for disabled people that couldn't chew, adults, old people, and infants, invalids and infants. In other words, infants shouldn't have to chew and learn how to chew. It's all wrong. There's a great book called Inventing Baby Food by Amy Bentley. Highly recommend it. It's an expose, just like the tobacco industry, just like the food and beverage industry now is being under scrutiny. So those are all things that sort of changed, and the jaws adapted. They okay, well, we'll just because there's no chewing going on, the bones will kind of warp a little bit and cave in, so they can just sort of mush their food and suck it down, and like those pouches that they have for kids now. It's in the even in the lay press, but in the scientific literature, that kids are eating baby food up until age 12. It's called, pouches. I always ask parents, new patients, does your child chew their vegetables or drink them? Do they suck them through a pouch? And that's just something that I think the dental oral health professionals should be asking, not just is the quality of nutrition and nutrients, vitamins, minerals, blah, 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 but texture. It's very important. I call it masticatory competence. So that's really, I want to establish in the ICD codes something called early childhood malocclusion. And that is jaws and teeth that don't line up properly under the age of 72 months old. Most orthodontists, let's look at them by age 7 and then maybe start treating them about 11. Well, that means that the malocclusion that was first discoverable and also as being identified is something that will become more complex without intervention. And sometimes myofunctional therapy can be an adjunct to orthodontic, or what we call dental facial orthopedic intervention. I'm doing palate expanders on kids as young as 2.5 to 3.5 years old. As long as they have 20 teeth, they can have those jaws unwarped. And then with myofunctional therapy and breathing exercises, these kids, they can really, it doesn't cure things any more than giving a 4-year-old who's nearsighted. If you give them glasses, which you shouldn't say, let's wait till they're driving a car. And often children who have really pretty pronounced malocclusions under the age of 6, they will be told, wait till they're 7 to get looked at and then treat them later. Then you only have to do it once. Well, that's like saying, only one pair of glasses, wait till they're driving a car, even if they're going to suffer with nearsightedness up until that age. That's a good analogy, and I use it a lot. So I say now, and the American Dental Association has established a task force on this 10 years ago under the direction of Steve Carstensen, to identify, do risk assessment, validated risk assessment of children as soon as in pediatric dentistry. We like to see them by or before age 1. First of all, to check for cavities, that and other anomalies, but malocclusion is now becoming part of what we look for, and to at least identify risk and inform parents, adult caregivers that this is something that will likely not self-correct. It will become more complex, and it's often comorbidly associated. That's a comorbidity. We say that often that malocclusion in children or at any age also will be associated with sleep and breathing disorders. It's very common. And often we never promise this. We try to assess risk, diagnose, put a treatment plan together to resolve the malocclusion because we're dentists. That's what we're trained to do. But it often, we tell parents, this might really also result in your child sleeping and breathing better, maybe paying attention better, maybe get them off their ADD meds, maybe doing better in school. Never promising, but it does happen, and there's literature that points to it. So does that make sense?
Yeah, so good. Such a good sort of progression of thought there with looking at the simplicity of the term, but the significance of it, and talking about what influence the body can experience when, when those issues exist, when really addressing them. I mean, it's so massively important. I know from, many of our colleagues like Renata Nama, who's a myofunctional therapist in the East Coast, and like we've mentioned a few, they're some of the ones that are huge advocates for work like yours, because there are so many others out there who, they say, just wait, like you said. And then I know that even Dr. Movahead was teaching recently in St. Louis on the regret syndrome that dentists can have when they later in their career at some point realize they said that to so many, and they realize now, or whenever this is, at that moment in time, that they've learned more. I think you as dentists have a lot to carry in terms of a lot of responsibility, a lot of, and it can feel like a burden, but it's such a
It's opportunity.
thing.
I call it opportunity to
Yeah.
really make a huge difference in a child's not only lifespan, that they might live longer. And there's evidence from the Dunedin study in New Zealand that suggests that often kids who sleep and breathe better, they have better impulse control. And impulse control is directly correlated with improved function as they age into the 30s and 40s. They look younger, they have less criminal behavior, less addictive behavior, and they avoid chronic disease. So that's the conjecture is that this might improve health span, meaning, okay, you not only live to 78, which is average lifespan now, you might make it to your kid might make it to 100, and they may not start to get chronic diseases till they're in their 90s, if at all. That's health span. Condensing more, morbidity is something we really want to do, is help kids optimize their lifespan potential and their health span potential. Another great book, Outlive by Peter Attia, talks about this whole concept of lifespan and health span. So this is, and cosmetics, that is the main portal by which kids enter into the orthodontic industry, is, crooked teeth and it doesn't look good. Well, straightening teeth, it's not rocket science, Invisalign, I mean, anybody can do that. It's not hard, but straightening teeth onto jaws that will accommodate habitually a tongue that's upward and forward in the mouth with the lips closed, for a lifetime while you're awake and asleep. That's the goal of at least recognizing risk under the age of 72 months, if not treating these kids sequentially.
Yeah, and I'm fully with you on that. It's in what I do in one aspect, I have the privilege of journeying with women, families before they conceive, and then conception, and then postpartum, and then seeing I love it when things are going so smoothly, but whenever there are issues with feeding, or nervous system regulation, and I can see that precious little infant and hold that baby and work subtly on the cranials or intraorally to help. And, of course, when there are those retrognathic mandibles on these little infants, and doing some good work to try to, create some change there. But, a lot of them end up needing, you know, getting to some really great providers, of course, with lactation consulting with the IBCLC field, but then also, having these oral ties released when they're there, and when they're finding this relief, these families, these moms, these, that it's profound. And then I see so many more are becoming educated in this, because they might not find this out there with their normal traditional healthcare providers. So they've had to go and look and search and find people like you, find people like me, find people like on Facebook forums and posting, and so people are now, they're aware, they're looking for answers, and they want to do whatever it takes, because they know that they're looking at longevity, and not just at this little baby, but they're looking at, I don't want because the other thing is they want to help their babies, and they do, and some come right away. Others, I'll see them right after the baby's born, and then like a few years later they come back and they're like, yeah, those things that we were talking about, what can we do now? And I'll say, all right, let's jump in. And wherever, but then often the parents, I'll work in their mouths and on them to demonstrate how they can work on their babies. And there you'll find it, the epigenetic stream of how far up the family line these issues arise and originate. So some people, they come into the game way late, and they didn't know. They never knew, because nobody ever told them. And I look at parents and I realize they want the best for their kids, for sure, because they don't want the kids to go through what they went through. But also they just know, if we're proactive about this, how much can we really change? And that's why I think your emphasis, and it's such an important thing, that yes, all ages can be helped to some degree, but how much more of these little, very plastic, and by plastic I mean supple and changeable beings, can be, if you can get to them early enough. And it's quite a privilege to be able to care for those families. I'm going to mention that we were just talking about briefly before, like Milt and I were, about the dyad, and yeah, just like you, I think I define the dyad as more of, whenever there's a parent or a caregiver that cares for a child, there's that relationship where you're kind of caring for more than just the one in front of you, but you're also caring for the family. And like you emphasize, it's most often like the mother, the nurturing component that there is, that, especially with feeding. But as we go up, even to like, that 2 to 5 year old, or, 2 to 6 year old range that you're talking about, how's it been through these years to journey with these families, when you see it's not, you have to look at them in addition to their little one, and how do you navigate that? How has it been to, navigate speaking to the one in front of you, the little one, and as well, like, educating the parents?
Well, it is parents, but not always. I mean, there's a lot of single parents that come in, and it's, sometimes we have Mr. Mom, Dad, but most often, and this is pretty ubiquitous in healthcare, at least in North America, US, it's female adult caregivers that we have our first encounters with. Most healthcare profession, pediatricians and peds ENTs and myofunctional therapists, certainly pediatric dentists, or primary care general dentists that see children. It's mothers. And I sort of got awakened. I mean, I was raised by a single mom, and I'm married to uh, a woman who's very forthright and has good instinct, and was taught to rely on her instinct as a kid. And I have 2 daughters, and we just kind of encourage them to follow their instincts. It's usually pretty darn accurate in terms of keeping you on the straight and narrow. And I don't know, might have been 10 or 12 years ago, I was approached by a woman, mom, who was, I don't know, I'm 5'6", on a good day with my shoes on. And she was maybe 4'10" or 4'11". And she said, "Dr. Boyd, can I talk to you a minute?" And she pulled me aside and she did this gently. And she just said, "You look at me, please. You know what, Dr. Kev? All my friends come to you. We've been coming to you for years. We love your work. We love your office. But you know what you're not real good at, Kev? Managing my expectations.
Mm.
Like, I thought we were going to be, after you fix this crossbite, and this was before I knew anything about airway, that we'd be good, and she changed me there,
Mm.
that then and there. And she wasn't as calm as I just presented that.
Yeah.
She was pissed. And to this day, I thank her for that, is that managing expectations, not just of the child, but that adult caregiver,
Mm.
mostly a mom or an aunt or a grandma or a nanny or, whatever, who's there. And a lot more dads are showing up. I love it.
Yeah.
Finally, you
Yeah.
know, um, and you just must manage potential anxiety. The parent won't always say, "Well, I had a bad experience with dentistry," or, they're nervous, and I think that's the lost art. Pediatric dentists, we get loads of didactic and clinical opportunities to work with what we call anxiety, behavior management, behavior guidance. It's not taught in the pre-doctoral. Dental students don't get this. And most kids who need pediatric dental care, let's leave orthodontics out of it, just cavities, um, are being treated by primary care general dentists, dental that graduated dental school and didn't specialize. And they're the best at it. They're so good at doing their best to try to do this, but they have not been, and there's published reports on this, is that dental school training for pediatric dentistry not having anything to do with orthodontics. Um, and orthodontics, they're just not taught at the undergrad level. And then they have to, luckily, there's lots of continuing education that they can do. Not so much in filling cavities and managing behavior, but orthodontics. There's lots now. And I just really am adamant. With this task force at the American Dental Association that has, published policy statements on assessment of kids at risk for sleep and breathing disorders. And malocclusion is something that is considered a possible indicator that there could be risks there. But there needs to be more courses like this in teaching how to manage anxiety in parents and children. And it needs to be taught to dental students, and it needs to be taught to orthodontists. It's not part of the curriculum. An orthodontic program can get certified by CODA. It's the Committee on Dental Accreditation. Um, they don't have to have 1 minute of coursework or clinical opportunities in managing anxiety in kids. It's not taught because most kids aren't treated till they're 10 or 11. So why would you need how to manage anxiety in a 3-year-old with a malocclusion? You shouldn't be treating them, is what the implication is. That's my opinion.
Mm-hmm.
And I think there's, lots of support for that this is something that must be ubiquitous to all oral health professionals, including myofunctional therapists, dental hygienists, speech pathologists. We're all oral health professionals.
Yeah,
Does that make
absolutely.
sense?
Yeah,
Yeah.
very
Yeah.
much, very much. Yeah, and I think, just keep thinking of, of course, how important that statement is, that it, because of, I think I'm just going to kind of, come out with this statement that, to not repeat anything you said because it was really good. Can't repeat it any better than you did. But if we can't care for the well-being, the emotional well-being, the nervous system state of a child, that is such a massive part of their management of safety, security in this world, and how they regulate. And of course, like you said,
Mm-hmm.
they rely on that nervous system regulation that comes from their caregiver, often their mom. And of course, that's such a crucial thing. But I'm, and I've taught on the social nervous system. That's an extension of Stephen Porges's work on the polyvagal theory. And I even have created sort of an airway specific nervous system conversation that I kind of stream throughout some of my work, my floor of the mouth protocol and other things. But the main point is that whenever there are these issues with the pharyngeal arches, that originate at that fourth, fifth week in utero gestation, and they lead to this malocclusion, and they lead to all of the components of that can happen. It's so evident that not only narrows, of course, the face and the arches, but it constricts the brain stem. It just doesn't allow for optimal brain to body connection, and so we see these these sensory processing issues. We see the children who have a hard time ramping down. They have a hard time settling. And for me, I knew early on as I cared for children before I had kids, I needed to really meet them where they were at. So that could look like if I've got a 2-year-old who can't sit on the table, can't lay down on the table, I can't expect him to get on the table and just listen. He wants to run around the room and play with my physio ball, the big, huge ball that you can sit on and exercise on, or, a lot of parents bounce on to get their kids to sleep sometimes. But I had to run around and throw that thing around and fly him in the air to do some cranial work and sacral work while I was flying him around the room, and then follow him at his pace so that by the time we got to the second or third visit, he just ran over, got on the table, and was calm as could be. That doesn't happen with every, some keep me running, some keep me active. But for me, I look at the way that the anxiety can manifest in so many different ways, and how to know what's really going on and how do we meet them where they're at. Because if we don't, we might never actually help them. They might not come back, and the parents might not feel like it's actually a lifting of burden. They might actually feel more stress when they're around. So I think it's so crucial, like you said, that it would become ubiquitous within all the oral health fields. Of course, I'm on a mission to teach all body workers. I've got a lot of myofunctional therapists in my courses, but all body workers that, you can know about all this, you can navigate this. And if we're not, we're often missing the root cause of so many of the things that you work on. So my training this weekend, teaching people how to work on the right iliopsoas, the hip flexor muscle, almost always that's, restricted because of floor of the mouth tension that happens in utero. And so I've walked body workers through, even if you don't work in the mouth for whatever reason, if you know that the origin of that issue could be from the mouth, who to refer them to and what providers can work with that and what providers are confident in that, because you may not know all the things, but at least you can spot some of these signs that are there and evident so that we can get these people, these kids, to the right places to get the help they need at a foundational, fundamental level so that they don't get tirelessly, escorted from one thing to another and never really have those root cause issues addressed until later on in life or ever. So that's a huge passion of mine as well. And I love that you make that such an emphasis, because we can really go far when we help people feel not only physically cared for, but validated, and affirmed. And so many parents, I think maybe you could speak to this too. So many parents come to me, and some of them have seen amazing people and all of that, but some of them have said, I knew there was something going on. I felt it
all the time.
Right?
Yeah.
Their instincts. Go ahead.
I see, again, mainly dealing with female adult caregivers, but I'm going to make a noise. This is what I hear a lot when and I treat parents like residents. Like, I've been in academic pediatric dentistry, and I've been a program director, and I've, been an attending, and we take them on rounds. And I kind of like to treat parents like residents. Like, I want them learning. I want them to see what I see. And when they see it, I often will hear this, I thought so. And it's mainly moms stamping their foot, meaning that they were marginalized by previous, caregivers. Oh, there's nothing wrong here. And that's how, my kid didn't get orthodontics till 10. Boyd's treating him at 3. He's not even an orthodontist. He's a pediatric dentist, and it doesn't happen so much anymore because of my alliance as a consultant at one of the largest tertiary care children's hospitals in the country, Lurie Children's. in working with Stephen Sheldon, is that, you know, it tends to have, I tend to have a little more credibility because, you know, this is, and I'm showing them this. Well, another thing I think that I'd like to introduce, and probably not to your audience, but this is a new concept to me, if I could steer it in sort of a pertinent direction. And, you know, you brought up in utero and fetal development. And this is something that's always fascinated me since Christian Guilleminault, who is the French pediatrician who came up with the term sleep apnea for children in 1976, published on 6 or 8 children. It was previously thought it was an adult disease. You know, like type 2 diabetes, that used to be maturity onset diabetes until it started affecting 4-year-olds in the 80s and 90s. But Dr. Guilleminault sort of called me out when I was taking a picture of him showing a study from France that talked about an angle that showed that the chin was back at about 20 weeks of age in utero on an ultrasound. And he sort of said, he pointed to me. There's like 300 people in the room in Chicago. And he goes, I'm going to, you know, ruin his accent, but Dr. Kevin Boyd is taking my picture now. And I thought he was going to throw me out. And then he really built me up. He said, as far as I know, Dr. Boyd is the only other person that's interested in this. I want to talk to you afterwards. I didn't even know he knew my name. Well, Mark Moeller, Joy's son, told me, Kevin, I've been talking to Christian about you for a long time. He knows you very well. And that's when I started to take an interest in this. Well, you know what has led me to is there's a couple of NIH studies going on, and this is something that I might be a part of at major institutions. Maybe not, but they seem, the PI, primary investigators, are very interested in my hypotheses about class 2 malocclusion, retrognathic, the chin being back, in utero. When Mariana Evans and I, who I work with, she's an orthodontist at University of Pennsylvania, she and I are visiting scholars in the Penn Museum of Anthropology and Archaeology. And we've done cone beam x-rays of skulls on babies through, you know, 50-year-olds that died hundreds of years ago. Well, on the fetuses, on the stillborn fetuses and early childhood, there's no kid before the Industrial Revolution that had a retrognathic mandible. You know, obviously we don't have ultrasounds, but we do have, you know, kids that were at 20 weeks gestation who died. Their chins are forward. So I was like, is this a modern phenomenon? Well, so right now people are curious about that. Well, I also now, as part of my orthodontic workup, I want a mid-gestational ultrasound. If I got a kid coming to me who's, you know, chin is back, I want to see what it looked like at 20 weeks. And, you know, this is something that people are very curious about. It's a hypothesis. Well, it's leading me to tell you this. Okay, when a kid is born preterm, they're at risk for something called apnea of prematurity and poor development of the jaws, narrowness and retrognathia, backwardness. Those are all things that are phenotypes that often show up in premature kids, low birth weight, preterm. Okay, where is the first place that a preterm child goes is to the NICU, the neonatal intensive care unit. And has anyone ever been? We used to round in the NICU. We used to take impressions of little preemies to make them little denture plates so that the feeding tubes didn't warp their palates. This was like at Iowa in 1985, or 86 when I trained there. What I did remember is that they're lit up 24/7, bright lights. Have you heard of the circadian code?
Oh, yeah.
Okay. The circadian code is trying to make, and this is at Notre Dame. There's a neonatologist there at Notre Dame. I can't remember his name. And then the author of this book, Sachin Panda, who's done all kinds of work, and it's leading to change. We have circadian clocks in all of our cells, all of our organs, all of our organ systems that are timed, and it's our activity, our hunger, satisfaction, our sleep cycles. And they are they can get out of whack, but they tend to right themselves once you get on it. I don't know much about this, but it makes sense. And what they're doing in NICUs now all over America is they're dimming the lights, they're dimming the noise. These preemies, they come out and they don't get to set that clock right. This could be related to some of these behaviors that we're seeing in kids. Again, I know enough to be dangerous about this now,
Right.
but I am so interested in this. If any of your audience knows about it, if they have comments, I recommend the circadian code. I'm on my second reading of it. So, those are things that can happen. The other thing I would like to bring up, Neel, you brought up Reza Movahed. Okay. Reza does surgical bimaxillary upper lower jaw protraction in non-growing people. So I proposed to him several years ago after he treated my daughter for bimaxillary retrusion. Now, she's 29 now, but when she was 3 or 4, I didn't know anything about this, and I did my best to widen her jaw and get her as far forward, but it wasn't enough. And she had sleep apnea. She had all kinds of problems. And Reza did a miracle on her, brought both jaws forward. And it just, I thought, Reza, am I right that most of the adult non-growing people that you treat by widening and bringing both of their jaws forward, they start out pre-surgical as both jaws being too narrow and too far back? And he said, yeah, you're right. Well, why don't we say that hypothetically, if I can get to these kids, in early childhood and widen their jaws and get them forward, they may not, and I'd call it non-surgical distraction, of growing this. They may not ever need your services. Now, I'm never going to put you out of business, but hypothetically, do you think there's something to this hypothesis? And finally, he's at least very curious about it. I don't know that he endorses it, but he's invited me. I'm not a speaker, but he's invited me to his meeting coming up this spring. And you also, some of the people that are going to be speaking there, and it's going to be really in St. Louis. So non-surgical distraction. If somebody as an adult needs both their jaws widened and brought forward, by definition, that means they were too far back and too narrow to begin with.
Yeah.
And then when does that start? It's become, it starts in early childhood. It's just not as complex. I never say it worsens to parents. I just said it will become more complex and a little more complex to treat. And my bias is I'd like to treat it now, or if we have a time machine, if they got a 7-year-old, wish we could go back to when they were 4, and it gets a laugh, but it's kind of true. We can't ignore it any more than we can ignore nearsightedness in a 4-year-old. It's incumbent upon us to at least make the parents aware this could cause other health deficits to the child if they can't see right. Well, what about sleeping and breathing right, and getting their jaws right and their faces right, getting them chewing hard food? That's kind of where I'm at. So.
I love it. Oh, so many good points that you made. And I get really passionate as well talking about embryology, because while I have some knowledge in that field, and I've done some studies in pre and perinatal birth psychology, I've kind of, if you at some point you look, and anybody that's been on, I've interviewed some of the foremost experts in certain aspects of embryology on my podcast, and some of them I just know who haven't been on. And I think it's so important to look at these things. And I get really excited about this initiative that your hypothesis, because I see it so clear. Like babies, right as soon as they're born, even if they've had wonderful home births, beautiful experiences in clinics without any intervention except for the nominal, these retrognathic recessed jaws are needing so much help to come forward. And so I, absolutely would say that they need, boy, and I say this to them, I say, if I could go back in time and work on your baby, I would, but I would work on you, and I would work on your grandma, because the egg that made you was when your mom was in her mom's, womb. And if we could go back as far as we could, I would go there. But we can't do that yet, right? We don't have the ability yet. So right now, all we can do is focus on where we're focusing, knowing that what we do today, what you do today, what you decide today may very well change not only the future of your child, but think about what they'll know growing up and what they'll be able to do differently. So I think mostly people feel hope with that. And so you might actually find like some of my audience who dives deep into embryology, dives deep into gestation, because that's their wheelhouse. They would love what you're talking about with that, and light as well. I've chatted with Molly Eastman, who knows a lot about light, but even Ben Greenfield, who is, I've been on his podcast, and there's a lot of people that light is such an important concept, and I think about it a lot, talk about it a lot. I see, there's so much to talk about there, but when I see there's this infant, especially, or even a child or even an adult, but I see them not responding well to what I'm doing intraorally, working on the floor of the mouth, working on the pterygoids, working on that fascia, underneath that mid-post tongue tie, or wherever they might be experiencing issues, and working on the bipalatine bones, trying to create some change to create some suppleness so that they can feed more easily or speak or move. And so when I'm seeing they're not responding, their nervous system isn't regulating, their dura, the dural tube tension under their occiput is too rigid, their muscle tone is too hypertonic. And of course I look at the other reasons that might be happening, and there's so many to say, but I'll say, let's change the lighting in the room. Let's dim those lights. Let's turn off the lights. And, of course, for a lot of these people that we're overstimulated by all these lights. I tend to not have very many lights. I tend to have just some easier, softer bulbs. And so almost instantly, we see everybody in the room come to a more relaxed phase, but then I see it discernibly when I feel their occiput begin to glide more easily, when the floor of the mouth tension decreases instantaneously when I haven't done any more work. So, and I look at some of those, we have OTs we work with and things where we can say, oh yeah, there's clearly sensory processing issues, but I don't think we need to label people as sensory processing disorder to know that the light is a problem in our era. And so, and I know some babies get sent over to the hospital to get blue light for, for jaundice. And I love saying to them, hey, the hospitals, thank God for the hospital, thank God for their amazing blue light that they have. However, like, we don't need more blue light. Blue light is actually, you can get that in the sun in healthy dosage. So it's going right. And I had one family where we step back and don't even talk about all the lights in a hospital, because I think you brought up so many pertinent points with the NICU. But I had one family who was dealing with a lot of hypersensitivity in their infant, and after he was doing really well, and I said, what'd you do? Did you go anywhere like a big department store or something like that? Did you? And they said, yeah, we went into Target. And I said, oh boy, I know Target, I love it, but Target has so much fluorescent lighting above. So as soon as they got home, they just did some candles and some regular lighting, and the baby settled so much, and that floor of mouth loosened some, and feeding was much better. And so, I'm kind of oversimplifying a main topic there, but I just want you to know it's so well received, I think, with people that are listening, and there's so much out there that points at we can modulate and shift so much to better our lives right now. And if we take these simple, small steps, they can amount to like massive, significant change. Now, to come back from that broad, overarching statement, I want to come back to like this. I just want to go back to the in utero discussion, if you would, and say that please, I want to be kept aware of some of that, because, I'm all of the amazing birth workers, lactation consultants, midwives that I consult with, or the OBGYNs, and then those like you who are caring for these children. It's so, and in fact, I'm just going to mention my bodywork system is called embryology, because it is built on the way we form. And I feel as a body worker, unless I look at the way we form, I cannot properly and accurately work on someone. In fact, when I worked on Reza, Dr. Movahead in the Bay Area. This was like a couple months ago. I worked on him out of his office, which I saw patients out of there on the next trip. And I found his left patella was superior. I hope he doesn't mind me sharing, but his left patella was an inch out of alignment. And he never knew. And I see the left patella out of alignment on most people who have a tongue tie, most people who have narrow arches, most people, they have that left patella, which is slightly superior. And so for me, I also get curious about that. And I think, so whenever I get the fortune of seeing some of these, the imaging from early on, it's really profound because we can see so many things started in utero, in gestation. And so what I guess I want to kind of like also, we could dive deep into the technicals, but how do you, I talked about this with Joy Moeller some, when you're navigating families and you say comments like that, where you're like, if only we could go back in time or a time machine. I know you see families who feel like this is so hard. I don't know. What can I do? If this has all been in motion epigenetically, what can I even do? Or they start to feel hopeless. What's your what would your message of hope and encouragement be to some of these families who...
The first thing that I do say, Neel, because people will come and they do their due diligence or they've talked to people and they'll say, oh my God, I'm too late. And as if, moms don't have enough on their plates when they're, pregnant and worried, or they just have a baby and all these things. And they don't need guilt. Like, oh, I should have known this. And like, no, your kid's 7. Hypothetically, this is something that was recognizable before that, but 7's better than 14. And I just try to show that, look, there's still opportunity to make a huge difference for this child. And so, that's the first thing. Another thing I think that I would like to talk about in terms of in utero, and I make the analogy when you're on an airplane with a child and you're getting the safety orders from the flight attendant. Place the mask on yourself before you try to help your child. Well, in the realm of nutrition, and that's what my master's is nutrition and dietetics.
Okay.
Is that they didn't teach me about chewing. They didn't teach me that oxygen is a nutrient. It's a respiratory substrate.
Right.
Proteins, carbohydrates, and fats are energy substrates. Structural substrates, there's different substrates. Well, oxygen is a nutrient. There's actually a paper that is called Mount Everest in Utero. Okay. Now, I'm going to give you this scenario. This is a paper published in 1953 based upon work done in the late 1800s by Sir James Barcroft, a physiologist who actually went on top at high altitude to test his hypothesis that the O2 pressure inside, delivered from the placenta to the fetus in the uterus, is tantamount to the top of Mount Everest. It's very thin. It's very low. Well, what Barcroft found out was he was wrong. It's not as thin atop Mount Everest, a mile above Mount Everest. That's how thin the air is within this being delivered. So there's no margin of error. A mom who smokes, the baby's small. That was an experiment that was inadvertently done. Yeah. Marlboro used to advertise their cigarettes to pregnant women. Don't you want to have a small baby, easy delivery, and the good taste of Winston? Oh, I have advertisements. I show it in my lectures. But certainly women who have sleep disordered breathing and snore, this is not good for the child. And it can predispose to intrauterine growth restriction because of the O2 demand, okay? And people born on top of mountains, they're smaller. Even women who are, give birth at sea level versus altitude, this is something that is really understood. So the fetus can really do well with low O2, but not that much. The flight attendant says, put it on yourself before you try to help your baby, because if you die, they're going to die, right? They don't say that, but that's what it is. is that pregnant women, it's called gestational apnea. This is another thing we need to do in terms of myofunctional therapy or respiratory therapy in utero, is the mom. They need to do yoga, they need to, eat healthy food, nutrients, but they need to breathe well too. So that is something that I think is very key and really missing, is that the negative consequences to a developing embryo turning into fetus, turning into, postnatal, neonate. These are things that a dentist should be there all along, an oral health professional. The other thing is the synapse network coming from the brainstem. This is right up your alley, Neel. And Dr. Stephen Sheldon, the neurologist, the pediatric neurologist that recruited me to sleep medicine at Lurie Children's, he's the one who brought forth from the University of Chicago Peter Huntenlacher was a neonatologist, and he measured synapses under microscopes. And the synaptic network coming from the brainstem to populate the frontal cortex is finished before age 4. That whole network is done before age 4. Who knows what's happening to these children who aren't breathing right before age 4? That is Stephen Sheldon's hypothesis, and he cited our work together of widening the jaw. We call it non-retractive orthodontics and dental facial orthopedics. We actually got an IRB exemption from it, which I'll go into later. But it's something that we don't know what brain damage could be done when they're populating the frontal cortex with the synaptic network. If they're not breathing and sleeping well, I said before age 6, I want to help them. Before age 7, certainly it should be even before that. We must assure optimal breathing, sleeping and breathing in children way before age 6, but certainly no later than. And I'm going to send you Stephen Sheldon's paper because it wasn't even published, and he and I ran into each other in the airport. We were both going to different meetings, and he said, "Kevin, I want you to read this. It's very pertinent to the work that he and I did together." And it has everything to do with populating synapses, the network, from the brainstem to the frontal cortex. Huge. This is just out too. This is brand new stuff. Can't wait to share it with you and get your input on it.
Oh, this is good. No, that has me. Yeah, for sure. You're speaking my language, but I think anybody who likes to go into the specifics of our development and that, and I do have, huge interest because of my, my kind of biochemistry, neuroscience, molecular biology background before I became a chiropractor was, delving into those intricacies. And of course, with what I do now, it is, we work on the body, but we look at the, like just like you said, and I think there's Shiriona Menzin Sills is a great practitioner in this field of pre and perinatal psychology and infant body work as well as adults. And she wrote a book called Spirit into Form, but it is a big book, 500 or so pages, and she covers embryo and gestation and in such detail. And she actually has a really good article in some bodies of research that she references from Mauro Zapatero, who is a Harvard MD who did a PhD on CSF, cerebrospinal fluid, and just looking at that and seeing how much happens. And so one of the things that she talked about, actually I interviewed her on my podcast as well, but she, I was talking to her about feeding and how important, of course, milk and nourishment and she said, yes, Neel, but what about the O2? What about the oxygen that comes through the umbilical? And I said, of course. So we did a deep dive into discussing that, but it is so good. I really loved hearing your,
I'll send you that paper, Mount Everest in Utero.
Oh, I love that.
I mean, Google it. And if you can't find it, it's an old paper. It's over 70 years old, but highly pertinent. Would love to share it with you. And actually, privately, publicly, I want to really pick your brain on this, Neel.
Mhm.
This is something that in also, the circadian code, how these things, this is a new area that
Yeah.
I think is going to be hot.
It is. You're so right. I'd love to. Let's continue. Our discussion, and then I want to. I'm going to mention something else, and then I also want to. Make sure we're aware of time, and you can let me know and fill me in on anything you need to do here with
Mhm.
our conclusion here. But with patients, there's I see. I'll mention something here that I think is really pertinent, and only mention this not to disparage anybody, because I think this is an affirmation to so many lactation consultants, so many people in the healing world. We care so much about our people, our patients, you know our parents and our caregivers who are working with their infants and their children. But I see so many people put on restrictive diets, cutting so many things out. And of course, I have a lot to say about glyphosate and gluten, and I have a lot of things to say about all of the impurities that exist in our soil and all of that. But I see so many families go crazy over restricting. I had one mom who she has twins and brought her babies in to me when I was last in the Bay Area, and she was put on by somebody a really restrictive diet, and she was like barely eating anything with caloric intake. And I said, you just need more calories. And it was actually EMF sensitivity that was creating reflux in her infant. So I said, you know what,
Wow.
the
Yeah.
EMF is important. So is the gluten, so is the all of that, the processed food, the grains. But I said, but I think of higher order things, you know, and this is a simple trite phrase, but we have, we can go so many days without food. We can go 4 days or so, 3 days of food without water, but how long can we go without air, right? And I also
Hmm.
say to many people, I say, if we can think about energy, metabolism, let's think about nourishment versus food, because I'm a big fan of food. I love it. I'm hungry right now, so I'm saying I'm excited about food. But I look at what's the kind of air we're getting, and of course we talk about air quality, but we also talk about the um, you know all of the things with malocclusion, all of the things with oral ties, all of the areas that result in these issues. But what's the air we're getting? What's the light we're getting? And what is the field of energy around us? What are the noises, whether it be electrical or EMF pollution? What's going on there? Because if we can address those things, that's ambiently affecting our body all the time. I look at that because if we can fix something there, we see dramatic change. And then let's move on to, for sure, your water. That's pretty much right up there with it. But then your food. So many families I've found are kind of looking at something and they're scrutinized something, and what we're missing is prevailing issues with our light, prevailing issues with our air. So I'm preaching to the choir with some of that, but for me, it's a conviction I have when I'm journeying with families to help us take the microscope off of the many things that could be playing a little role and look at the things that are possibly massive that we can shift. And so many people say, well, I don't know what I can do. I can't, how can I get rid of the EMF? How can I get rid of the light issues? And I'm saying small steps. It doesn't take much, but if we can address the main things, I can go into, we could always do it, hey, maybe you and I can do another conversation where we go into deeper dives. I feel like there's so much that we could talk about, but I don't want to go deep into the weeds on that. And I want to kind of pull back to say, um, I think that talking about these issues, like you've alluded to, are part of the epigenetic factors that are so prevalent. And when I see cases now, I see people who have seen, 4, 5, 10, 11, 12 other people in the health field. And I tend to look at, but what's going on beneath all that? Because you've had failed procedures. And if we can identify some of these epigenetic triggers and shift something, that can often be the thing that really results in some change that the people have been missing.
So bringing up epigenetics above the genome, that's what it means. Obviously, you know that. But um, what is really missing from the conversation, and even with you, I would love to share some of this, because how many chiropractic schools teach or require chiropractic school, like, pre any professional degree, that you take at least one course in anthropology or evolutionary biology. Do you know how natural selection works? It's real basic. And there's a whole framework in medical education now called evolutionary medicine. I encourage everyone to just Google evolutionary medicine and the word Nesse, Nesse, Randolph Nesse, Why We Get Sick, is a paperback. Read that book. It's it should be a prereq that we understand how natural selection works. Like, why do things go extinct? Why do things get weeded out of the genome over the millions of years that it took our genome to form? And again, it's a rhetorical question, but once we can answer that, once we know how natural selection works, why does it select for things and weed it out? And then you say, well, how come natural selection didn't get rid of fever? It's miserable. It makes us miserable. And the simple answer is approximate versus evolutionary reason, approximate cause or an evolutionary reason. Approximate cause of fever, the immediate cause of fever, is pathogens entering the bloodstream, okay? But the evolutionary reason for raising our temperature when pathogens are in there, it makes life awful for us, maybe even shortens or ends our life, but it's 100% fatal to the pathogens that enter the blood. That's why natural selection hung on to it, is that because it enhanced the ability to survive long enough to pass on your genes to reproduce. Well, there's all things got to be thought about that way. Is that how come malocclusion? How come impacted wisdom teeth? Well, you know what? It's sort of like the jaws needed to be stimulated from in utero, in birth, sucking amniotic fluid and then coming out and being nursed and weaned until they're 3 or 4 and being baby-led weaned onto hard foods, fresh foods. That's what natural selection selected for. Jaws and muscles that were able to form that, and it's connected to the respiratory system. So if the craniofacial masticatory complex is absolutely optimized in early life, so will the respiratory tract. Unless you get a busted nose or there's other things that can go wrong, but under non-outlying situations, this is what we need to do. And all the things that you fix, all the maladies you mentioned, Peter, and the polyvagal theory, is that all those things, what is it? We got to start thinking about it from an evolutionary perspective. Why is it that the floor of the mouth portends that this is going to, cause tension here? I don't, I just think we got to start thinking about things from an evolutionary perspective, not just approximate cause. That would probably be, if you carry anything over, malocclusion, skeletal hypoplastic malocclusion of jaws and faces and teeth and airways. Its antecedents are first there at birth, certainly before 6 years old. They will persist. They won't self-correct. They always become more complex. They can often become associated with respiratory and neurological, cardiovascular comorbidity. That's what I want to be remembered by. So that's, we're going to have to conclude pretty soon because I got to go down into my clinic.
Sure.
So what do you think? You got any concluding
great.
things?
I think you've got in there like a great kind of summarizing, kind of concluding phrase, and I love it. And it is a call
good.
to action, I think, in there too. I think I can see inherent in what you said is a call to action for us. I'll just kind of note that, I studied extensively anthropology. I studied extensively in
Great
biology, and we had Bruce Lipton present to us in our fourth year at Palmer Chiropractic
He's
College.
My hero.
Well,
I love Bruce Lipton.
We hung out with him in 2005 because he presented to us. So
he changed my life in like the 90s. Imaginal cells, so cool. The monarch butterfly arising from the phoenix, the caterpillar. Yeah. Did he ever talk to you about the imaginal cell of the cocoon?
I've seen it.
Oh, my God.
Yeah.
I love Bruce Lipton. Thank you for bringing him up.
Oh, that's so wonderful.
Wow.
Yeah,
Do you know
and
him?
no,
I mean, do you? Oh,
no, don't know him personally. No, just we
oh,
met
man.
because he was talking to a group of us. So
Yeah.
it was one spot in time. Although I've loved his work and followed it. So
Oh God, sorry, didn't mean to interrupt you. I just like that struck a nerve with me. I love that man.
oh, that's
Oh,
so great. And
yeah, it's incredible.
yourself, do you know him?
No, I got on at the end of a Q&A, and he actually responded to my question. So we had an exchange. I heard his voice, but yeah, I just love the guy. He's a molecular biologist, taught anatomy in medical school at Wisconsin, and left it all.
Yeah.
And he's the one who discovered epigenetics,
Yes.
uh,
That's what he
like
presented to us about.
way before anyone else was even talking about it.
Yeah, and he presented to
Um,
us because I think that's one of the things I loved about our education is, kind of it was built to teach us how much is really there, how much is possible, and what led to all this. So that even though we didn't dive deep into that in our actual training, so that's where I kind of have pursued more passionately that post, graduation. And that's back 2008. I graduated from chiropractic college, and so his work has really influenced me greatly, and so then there are many others out there who I can say, like, including my dad, who's a cardiologist, and he's a detective, and looks at, like, yeah, but why and where does it come from? So I appreciate that about you, because there's a part of my life where I've spent fixing, it's like triage, helping the people with the issues they have, because who else is going to, and who else knows enough. But then we've got to really start, and I've started to then say, okay, in this phase, I can now start to go back a little bit before, a little bit earlier, and so get back into what is really the crux of all of this. And with the floor of the mouth, I have so much in the works with that. I've got a lot in the works with looking into all that more, but I've got a lot of sort of research compiled, and I'll be picking your brain about that. But I know you mentioned it too. We've got to come to a conclusion here soon. So there's going to be show notes that have all the ways that people can find you, and all the ways that people can learn
Yeah,
from you.
please give my email to anybody anytime. I've cut my clinical commitment here from 5 days a week to three, and I'm teaching, I'm doing research, I'm still at my office, even though Thursday's not a clinic day for me anymore, but I'm being called down there, so I got to get down. But one more Bruce Lipton thing. Do you know when the Genome Project, disclosed that there's some 20,000 genes
Yeah.
in the human genome, and they were looking for maybe over 150,000 because there's 150,000 proteins, hormones, and structural proteins, and oh my gosh, like 20,000 genes code for all those proteins. And he called it a cosmic joke
Yeah.
because
Yeah.
everybody thought it was one gene, one enzyme, or one
Oh
gene,
yeah.
one protein, and one gene
Mm.
can code for hundreds, if not thousands of proteins. I just like, wow. Well, this has been great. If I was a cat, I'd be purring right now.
Oh,
This
that's
has
so
really
good.
been a great, and I look forward um, to really sharing common interest together with you. Is your cardiologist father still living?
Yes. Yes.
Well, maybe, I got some cardiology stuff as it relates to sleep apnea in little kids and risk for cardiovascular disease and cardiorespiratory fitness. Ask your dad about, CRF, cardiorespiratory fitness, because little kids who have sleep breathing disorders, they're at high risk for really poor cardiorespiratory fitness. Um, but again, I know enough to be dangerous. So
Yeah.
want to learn more.
Yeah, no, I'll say that, with molecular biology being a path that I was going to pursue not too long after the Human Genome Project, and I got into it, and I thought I could do this. And there was always this talk about, will I follow in my dad's footsteps and become a cardiologist? And I respect his field and him greatly. And then I thought molecular biology is the way that I could get advanced and get ahead and look into the future. But I just had enough intuition to know that's not the future, and stumbled into chiropractic to hear Bruce Lipton talk epigenetics, and then now being the work that I'm doing. And I thought, how wild and crazy is that? But I
Yeah.
think there's a huge overlap. And well, anyways, I could, we'll talk another time about the soleus muscle, right? And how that is like the second heart, and that influences the cardiorespiratory system significantly, and how I see in like 99 out of 100 babies with tongue tie or narrow arch, that soleus is restricted on both sides. And so the body's so complex. And yet there's so much that we could say that if we stick to the simple, clear things like you've mentioned, there's so much that can be possible, so much that can be done. So I'm eager for our future conversations. I'm eager for people to look you up. And what's aside from your email, is it your Facebook page, or where can people find out more about you? That's the easiest, just to kind of throw out there, knowing I'll get it all in the show notes too, but just in case anybody's just
Yeah.
listening.
I don't, if my daughters aren't home, I don't know Instagram, Facebook, any, in my office, I know we have pages and all these. So the best thing to do, my office phone number is 312-988-9855. My office manager is Orla. She's delightful. She's brilliant. And she knows how to guide people to where, what, and how. And yeah,
Sounds
so
good.
great. I
Great.
hope that isn't too much self-promoting there, but I
No,
just
not
want to
at all.
help people do it.
No, that's
Um,
great. Milt gave me the secret code about how to get to you, and so I used that. No,
good.
I'm just kidding. But no, that's great. I'm sure people will
Yeah.
appreciate that. And we'll be definitely eager for people to tune in, listen, and of course I want everybody to check out Dr. Kev and Dr. Boyd's work, and seek him out. He is such a phenomenal person, caring person, and renowned expert. And so until we meet again, Kevin, I look forward to this, and I'll be updating you. And if you would hang out for one moment here after we end recording, we can catch up. But otherwise, thanks so much for your time. It's a great privilege and pleasure.
You're welcome, Neil. You're a excellent host and great interviewer, and I've really enjoyed this and look forward to more interaction with you. So thank you.